motor inhibition, but at a different motor pool than the spinal ones. And Ralph initiated in sleep a critical topics forum, some very learned articles, but it's fair to say that there was some, they varied from being very, what's the nice way to put this? There was some mild scholarly discussion through to some rather aggressive language in certain areas, and I won't. But the point was, it was a spirited debate, I think, is what I'm trying to suggest. And that is a good thing in science, because it led to some discussion. One of the issues was, which I think is fair, it's okay to say, well, I'll show you the evidence that glycine and GABA are not significantly involved in the motor inhibition, but, well, okay, well, what's left? What is doing this inhibition? I think that was a very fair issue. And I think we've identified that missing mechanism now. So, if this scenario is correct, that there is minimal glycine and GABAergic inhibition pre-REM and lots of it during REM, then there is a predictable response to blocking glycine and GABA. Now, if you block glycine and GABA individually or together at the hypoglossal motor pool, you release inhibition. But look, you release it across every state, but least of all in REM sleep, which is a priori not what you'd predict from this model. Exactly the same effect happens at the trigeminal motor pool. Both important motor pools modulating the upper airway. Release is found in motor activity in all states, but least of all in REM. So this is really not what you would suggest. This provides very little evidence for a glycine and GABAergic inhibition. So what might be mediating it? Well, we hypothesize that acetylcholine may. This is the identified modulation of the upper airway musculature by acetylcholine in relation to the transmission of respiratory drive through glutamate, but also there are cholinergic receptors on the motor pool itself also, as well as presynaptically. The question is this mechanism operating in REM? And such that this is the reason why there is profound motor inhibition to the tongue musculature in REM sleep. This paper was published in the American Journal of Respiratory and Critical Medicine earlier this year, and we did a simple thing. We targeted the hypoglossal motor pool, and in the initial experiment, we had the idea that, well, so this is, I'll just walk you through this because you'll be able to see it in the next slides. This is tongue muscle activity in non-REM sleep. You can see this inhibition in REM sleep. The upper airway has periods of profound inhibition, but also transient motor activations too. You see this in rats, you see it in cats, you see it in dogs, and you see it in humans, and it's thought to be responsible for the sporadic reopening of the airway in REM sleep occasionally. But I want to focus on the periods of motor inhibition. If we block the cholinergic input, we saw something that we have never seen in 10 years' work. And that is a complete restoration of motor activity, a complete rescue of motor activity throughout REM sleep simply by blocking the cholinergic input. And the second thing, the details in the paper, the response was largest in REM sleep and less in the other states. So summarized, we reverse REM sleep motor suppression, most of all in REM sleep, but this is equally important. There is a return of physiological patterns of activity, normal respiratory modulation, and we had never seen this before. We can do a similar experiment, but now blocking the potassium, the hypothesized potassium pathway, and we see the same thing. A complete rescue of motor activity, again, largely in REM sleep compared to the other states, and it was a return of physiological patterns of activity. So this is implying that in REM sleep, there is a cholinergic influence and a potassium efflux, which if you've got lots of positive ions leaving a cell, it becomes more negative inside. So instead of a glycine GABAergic inhibition, you can have potassium efflux producing the same thing. It doesn't show that these two are connected, however, and this was the final experiment where we had a control condition and a control level of muscle activity. We then locally applied a brief pulse of a muscarinic receptor agonist and got a predictable brief inhibition, which then went away when we washed the drug out. We then blocked the GERK channels with tertiarpin Q, did the same thing, this brief intervention, and got a powerful suppression of response, okay? Showing that there is a functional link between these cholinergic and the GERK channel mechanism. And I will propose that it's this mechanism that's responsible for the powerful motor inhibition in REM sleep. We think the source of inhibition is these premotor cells and the adjacent reticular formation, but that has yet to be proven. But I will suggest that this mechanism has been put in place for whatever reason by biology, and it's a mechanism that is recruited in a natural state of REM sleep, but it's a cholinergic pathway. There are times when drugs that increase endogenous acetylcholine are given for medical reasons, and they're just going to address the same pathway. So there are times when, for example, acetylcholinesterase inhibitors are given, and we locally applied acetylcholinesterase inhibitors to this hypoglossal motor pool, and you get marked suppression of motor activity, now across every state, because now this drug is there all the time. The implications are that in conditions where acetylcholinesterase inhibitors are given, and here's a recent paper a few years ago by Matthias Eichermann, that there can be upper airway dysfunction, and I would propose that it's simply hijacking the same system that's causing REM sleep motor inhibition. Now, I'm just going to switch you away from now the fundamental biology and see how can we use this information. And this really focused our attention on the control of breathing by potassium channels, which myself hadn't really focused on before until very recently. And this is where the collaboration with Stuart Hughes came in, who contacted me. We got on very well, and we had a very productive collaboration because he's a real expert in potassium channel biology. And he reviewed all the potassium channels that are present at the hypoglossal motor pool. There's 4 families with multiple receptor subtypes. This is too small to read, but the point is that there are multiple receptor subtypes, and some of them can be blocked with certain drugs. Okay, so we can block the voltage-gated different families with drugs called TEA, 4AP. We can block certain channels with barium. This blocks the GERK, which I just mentioned previously. And I highlight this one, KIR 2.4. I'll tell you why in a second. And we also targeted TAS channels, which some of you may be aware of with certain drugs. These are actually of special interest because these are modulated by neuromodulators which are highly active in wake and less active asleep. And the idea was that this is the reason why upper airway muscle activity decreases in sleep compared to wakefulness. Okay, I've got just a couple of minutes and I'm going to finish. I highlight KR 2.4 because this has no known agonists. There is no known agents that can modulate this channel, but these other ones do. And this is actually a high region for opportunity for a reason I'll mention. So if we were to step back and say, let's forget that we know the biology, that's a good thing because it's good to know how things work. But let's say, how can we just manipulate the system to beneficial effect? And here we've applied barium to the hypoglossal motor pool to block inwardly rectifying potassium channels. And you can see it has what we would consider a beneficial effect if you were aiming to reactivate the pharyngeal muscle activity across sleep-wake states. And most importantly, there's no other really interventions that can reactivate muscle activity in REM. And so this is able to do so. It can rescue it. Interestingly, so we can target these channels quite selectively, and importantly, there's physiological patterns of activation. Methandamide only activated in wakefulness. That's a very interesting result, but not so much for today, not in sleep. The other drugs blocking the other channels had beneficial effects. Why would I highlight KR 2.4? There's been an interest in developing pharmacotherapies for sleep apnea, modulating serotonin, for example, modulating other receptors and such. I would propose that that is not a viable mechanism given how ubiquitously expressed throughout the brain. The interest for me would be to target targets that are very highly regionally expressed. And it turns out that KR 2.4, this subunit of a potassium channel, which if you modulate it has beneficial effects, activating motor activity across all sleep-wake states, is only expressed, and this is the amazing, only in the cells that drive the upper airway musculature. It's in the hypoglossal motor pool, it's in the trigeminal motor pool, and the facial, and nowhere else. Very promising. I will skip this in the interest of time. skip that. Just mentioning here that GABA exerts powerful influences on brain sedation, but also can influence breathing. And I just want to wrap up this, this perhaps, I think, a misinterpretation of what GABA and glycine are doing. We tend to consider GABA as causing motor inhibition through activation of synaptic GABA receptors and through augmentation of these sporadic and transient GABA receptor inhibitory potentials. But there are extrasynaptic GABA receptors which produce tonic inhibition, which are strongly modulated by anesthetics and other agents. And they're exquisitely sensitive to GABA. So they respond to spillover, and so exquisite they've been considered the one glass of wine receptor. So you can imagine what 2 glasses of wine may do. And this, I believe, these extrasynaptic GABA receptors are why there is release of tonic motor activity across all states with GABA antagonists. So we developed, in collaboration with Beverly Orser, some delta subunit knockout mice, and we can give an agonist for the delta subunit in normal rats. You can see this clear suppression of tongue muscle activity, and its reactivation with GABA blockade, which blocks everything as well as extrasynaptic, blocks these transient too. You do the same thing in a wild-type mouse. You can see clear suppression of upper area motor activity with an extrasynaptic GABA-A receptor-preferring agonist, and no response whatsoever in the knockout mice that doesn't have these subunits. And likewise, this can also be a source of respiratory depression because systemic injection of this sedative drug causes respiratory rate depression, but not in the knockout mice. I'm just going to finish because of time. So I've tried to highlight that there is a population of people who have sleep apnea, many of which are undiagnosed. I've described to you that there are agents such as hypnotics of the type I've just described, which can depress breathing through augmenting tonic inhibition. There's this powerful suppression of opioids, suppressing both the upper area musculature and the respiratory rhythm. And there is one of the most widely prescribed drugs in the Western world as a sleep aid is ethanol. And these work through the same mechanisms. And so you've got this potential element of risk where some of these drugs themselves can depress breathing, particularly if they're combined with ethanol, and particularly in the home. I will finish there just to conclude that we've just recently developed funding from various sources. And for us, this is very exciting because the Department of Medicine has committed funds now to grow this field merging sleep, sedation, and anesthetic sciences, and we've generated significant funding from the Department of Medicine, plus other partners, but most importantly, including allied departments at our Faculty of Medicine. The Faculty of Medicine themselves have contributed funding too. So it's really launching a group of investigators. Some of these people you'll know. Francis here is a valuable partner, but we're spanning really a bunch of disciplines. I'll just leave this up as the last slide. From basic science through public health, a variety of research projects involving a variety of stakeholders. So this is just a very exciting time, which I think is, and one of the stimuluses for this is a meeting like this gave us the impetus for it. And as I mentioned, people like Ralph who've pioneered this kind of merging of these subjects over the years. So thank you for your attention.
Thank you, Rich. Great talk. We're running a little bit behind, so maybe just we'll take a couple of questions if there are any, but we're going to have time for Q&A after our third talk. So any questions for Richard?
Well, you could say the same thing for mu receptors being elsewhere. I mean, there are endogenous there are endorphins for various reasons. I think that what I've read about is that they're very important. There's an opioid surge at birth, and then it could be that the subsequent stabilization of breathing, that's one of the things that Jack Feldman has talked about. But there we have the issue between why is this happening and why evolution didn't put things in place for us to then develop drugs to manipulate the system later on. Didn't envisage that, right? So the fact that these are there, I think, is the point. And the fact that I think it's disappointing from a therapeutic point of view that it's very hard to separate. If the neurokinin 1 receptor mu-opioid complex is the crucial thing, it means really you can't separate pain from breathing. So it could be that it's good to have the knowledge base, but it might not be possible to divorce pain from breathing and keep breathing in the presence of mu-opioid receptor modulating drugs. It might be you have to just bypass that system. So we don't know why they're there, but the fact is they are, and if you stimulate them, they can do bad things.
And isn't it fascinating that so many cultures have used breathing to modulate pain? And I think it's a very interesting question. We should be reminded that red blood cells also contain opioid receptors.
Yeah. And white blood cells contain GABA receptors.
You referred in pattern generation to tidal volume and the rate. What about regularity of rhythm generation? What's the explanation for those atypical breathing patterns developed during sleep?
Yeah, it's a great question. We saw the same thing. We didn't see, if you're familiar with the idea of quantal breathing, we didn't see quantal breathing as Jack Feldman has described. We did see, I didn't have time to, we did quantify variability. Breathing is highly variable. And we have a collaboration with Indra Narang at the Hospital for Sick Children to try and work together with modulating these findings with state dependency. And there's an increase in variability there too. And part of our mission is to do the same types of detailed electroencephalographic analysis coupled with breathing in the presence and absence of opioid drugs. And the preliminary kind of findings are that we see very much a recapitulation of these findings. What we would perhaps envisage is that they would be most similar in very young ages. And as the individual gets older, as the brain becomes more complex, that we might lose that signal that you see in the rodents, but it's there at young ages. That's our idea. Yep. We haven't, but our collaborator Beverly Orser has. She's mainly focused on the alpha-5, and the interesting thing is anesthetics upregulate the alpha-5 and you cause impaired cognition that you can disrupt that increased regulation of alpha-5 and you can restore cognition. And I think she has preliminary evidence showing the same thing with the deltas. And our particular interest is this link to respiratory depression. So do anesthetics and or inflammation upregulate extrasynaptic GABA-A receptors and put the brain in a situation where it's closer to being more sedated than it would otherwise be in response to the same GABA drugs. We should, in the absence of our chair, I think we should probably move on to, should we move on?
We need to change laptops, so.
Yeah. So where is he?
She's coming with the laptop.
I can take more questions.
Yeah, go ahead.
Yes.
Oh, there'll be no questions for Richard at the Q&A. Just kidding.
This is a great question. I think the evidence for the masking effect, I mean, this has been around for a long time, this idea of the wakefulness stimulus to breathing that both Elliot Phillipson, Fink, and John Oram has described with how you, for example, if you lower CO2, you can get apneas only in sleep, and you don't get them in anesthesia, you don't get them in wakefulness. I think it will be perhaps a very long time, because it's what you do about it. And that's the elephant in the room. You can see someone and say, are you okay? You have these, you can do all these tests. And then later on, they fall asleep in the middle of the night, and there's also a circadian modulation of breathing and arousability. And you have a recipe in some people where that can be a very serious problem. And I'm not sure, apart from putting monitors on people, what the issues would be. Because there's a resource issue, isn't it? Yeah. We had the decision to study ampakines, but we knew that was being done very well elsewhere by John Greer. And so we decided to focus on how it is that the opioids are depressed, because that wasn't known. And the ampakines and the 5-HT4A receptors work bypasses. You don't need the knowledge of how the opioids are working, and we felt that that was actually, from a biological perspective, an important thing to do, and that's what we pursued. But ampakines work very well.
Thank you, Richard. So moving along, our next keynote speaker is Dr. Shahrukh Javaheri, who is Professor Emeritus of Medicine at the University of Cincinnati. And Dr. Javaheri, I'm quite excited to have you here because, not to show my age or yours, but when I was a sleep fellow in training, we used to do journal club on the articles you've published. He's been a leader in the field of sleep medicine, trying to understand the mechanisms by which we get central sleep apnea in heart failure and in, with opioids. So I think it's quite relevant to the field of sleep and anesthesia. Dr. Javaheri, please.
Thank you so much, Babak. I appreciate the...
You have to move the slides from here, and this is the pointer.
The slides from here. Yeah, thank you so much for the invitation. I certainly appreciate the honor. Actually, I thought there would be someone else who will talk about obstructive sleep apnea, and I then realized that it is my task to talk about central sleep apnea, but really most of what I will say probably will apply to obstructive sleep apnea. And thanks, Richard, for setting the stage with the beautiful work you and Jack Feldman have done in this regard. I want to ask the audience if they can look at this polysomnogram and tell me what is wrong with the patient. I'm sorry? Congestive heart failure, you said? Yeah. This is actually Hunter Cheyne-Stokes breathing. Dr. Hunter described it 37 years before Cheyne described it. It's a very beautiful demonstration of a patient with congestive heart failure. So these are 30 seconds intervals. You can see beautiful crescendo, decrescendo changes, central apneas occurring regularly, the same duration, very, very beautiful polysomnogram. What about this one? This is a patient on opioids, and you can see the difference between this pattern and the other pattern. Frankly, anyone who does sleep studies and look at these patterns should be able to diagnose this quickly. And here now we have central apneas, obstructive hypopneas. Central apneas are of different durations. Hypopneas are of different durations. Out of apnea, sometimes breathing is fast and very, very large tidal volumes, sometimes very small tidal volumes, a very chaotic pattern of breathing, very, very chaotic. It's two patterns in the background, the so-called Bayet breathing and ataxic breathing, which are a little bit different. It looks to me that looking at the opioid patients, it is the ataxic breathing that is the more prevalent pattern in the background. But again, as I emphasized yesterday, these patients really have, and I'm a lumper here, not a splitter. If you think about an umbrella here, this is the kind of breathing I would call complex sleep apnea, where there is both central components of the sleep breathing disorders as well as the obstructive. So it's just a very chaotic pattern of both obstructive and central sleep apnea. Now, let me talk about the prevalence, and again, there are two forms of central sleep apnea that I will discuss in a moment. One is when you see a virgin patient, that is a patient that just comes to your office with symptoms of excessive daytime sleepiness and so on and so forth. Mostly they come to my office because the doctors felt that these patients have obstructive sleep apnea. And then what we find is that we find a lot of central sleep apnea in the midst of the obstructive sleep apnea in these patients. And then the other form of the central sleep apnea is when they actually have obstructive sleep apnea. Primarily, you put them on CPAP, and then they develop central sleep apnea. This is where it has been termed complex sleep apnea. But really, again, I would like to use complex sleep apnea as a as a lumper here of when I look at the polysomnogram and I see both obstructive and central components together. Let's just talk about the updated data on what is the prevalence of sleep apnea in this country. These are the updated data just published a month or two ago. Is the author on this here or not? Yeah, these are the data from Dr. Young, Peppard and Young, and the prevalence of sleep apnea, comparing the data from 1998 to 1994, that's the paper in the New Journal of Medicine. You can see the prevalence of individuals having sleep apnea, not the syndrome, has gone up from 6 to 10% for 30 to 49 in men, and from 14 to 17. Oh, sorry. Yep, thank you. Appreciate that. So there has been some significant rise in the prevalence of sleep apnea in this country. Again, remember, these are primarily obstructive sleep apneas and hypopneas. And this is also true in women as well, although the rise in women is not as much as the rise in men. So we're talking about a prevalence of about 10 to 17% in men and about 9% or so in women. So if you look at now what is happening in with the opioids. So these are some of the data. This is from Webster et al., published in Pain in 2008. These are about 140 patients out of 392 that underwent polysomnography. So if you look at the AHI of less than 5, only 25% had AHI of less than 5. So 75% of patients with opioids have an AHI of more than 5. And if the numbers look at that, 50% of the patients on opioids have an AHI of 15 or more per hour. So the prevalence of sleep apnea in opioids goes up tremendously compared to random population, so to speak. And there are multiple studies, of course, on opioids that have looked at this. This is the other study that was published in Sleep Breathe in 2009. Again, very consistent data. 85% of the patient had an AHI of more than 5 per hour, and almost 50% have an AHI of 15 or more per hour. So these are really tremendous numbers of patients on opioids having sleep apnea. This is the Wang data. Again, here we're looking at central sleep apnea. You can again see the prevalence of central sleep apnea is quite elevated. Now, please remember, central sleep apnea in general population is very rare, unless you have some conditions such as opioids, congestive heart failure, neuromuscular disease, and some of the neurodegenerative diseases that perhaps may involve proboscis complex causing some central apnea. Otherwise, central sleep apnea in random population is extremely, extremely rare disorder. So here we're talking about a huge number of central apneas, again, occurring in the background of obstructive disorder breathing events. So I don't want to come up with the idea that these patients have pure central apnea. That is really not the case. Another study by Sharkey et al. Showing that the central apneas are indeed highly prevalent. Again, in this particular study, you can see 44% of the patients had an AHI of more than 5, and a lot of them had a lot of central apneas. Dr. Farney was kind enough to let me have his slide on this medication now, buprenorphine, a semisynthetic agonist that is used for opioid dependency. And the concept here was that perhaps this particular drug does not depress breathing during sleep. And thanks to his work, indeed, that this medication is as bad as other opioids, So he's looking at consecutive patients here, and that's a very important point. 70 consecutive patients that were on this Suboxone, which is buprenorphine, a little bit of the, primarily buprenorphine. And the mean AHI of these patients was about 20 per hour, and the CAI was 11. Again, we're talking about a combination of obstructive and central sleep disorder breathing events. 63% had an AHI of more than 5 per hour, and 17 more than 30 per hour. So these are really huge numbers again. It's unfortunate that some years ago, let me come back to, let me finish with his work, in fact, which is very interesting. And 61% had an AHI of more than 5 per hour, 33% an AHI of 15 or more per hour, and 17% AHI of 30 or more per hour. Again, these are consecutive patients. This is a very good study because it really is looking at consecutive patients with the, on buprenorphine. And here are the breakdown for the central sleep apnea. Again, remember two things. Sleep apnea in general, highly prevalent in opioids, and then there are a bunch of central apneas in the middle of the obstructive events. Here is the summary of the central apnea. 30% had a CAI of 5 or more per hour, 20% CAI of 15 or more per hour, and 9% more than 30 per hour. If I combine these 5 studies together, so we have 436 patients here. I think the next slide will show the summary of all of that. So if we combine all these studies together, you will see that 35% of the population with opioids have about AHI of a CAI of more than 5 per hour, and then 20% is 15 or more, and 10% more than 30. These are huge, huge, huge numbers. And there are new medications that are being approved by FDA for the so-called opioid dependency. This is one of them, which is similar to, but this is a sublingual medication that was just approved. You know, yesterday, the day before yesterday, before I came here, in Ohio, 5 individuals die per day because of the opioids. This is the data from Ohio. When we talk about the tri-state, the state below us is Kentucky, which is really the capital of the world for opioids. I don't know the data from there, but it should be really amazing when you look at how many people in this country are actually dying with opioids. And frankly, the sine qua non of death is a terminal apnea. The sine qua non of death is a terminal apnea. So we're talking about a very important issue here. So again, I will be talking primarily in central apnea, but the treatment that I will be discussing probably applies to both. As Richard indicated, and Feldman data, consistent with Richard's data, that both hypoglossal motor neuron pain as well as prebolstein complex are involved and suppressed by the opioids, as he discussed very elegantly. Now, this is the obstructive sleep apnea. This is the study from Stanford by Guilleminault and Michelle Cow. These are 42 patients that were on opioids and were referred to the center. And all of them had obstructive sleep apnea. These patients were, some of them were on opioid pump, as you can see. And on the diagnostic study, look at the age. Well, I don't have the mean age, but these are generally very, very, very young individuals as well. So these were people that were referred to the center for symptoms of obstructive sleep apnea, and indeed, these 42 patients had primarily obstructive sleep apnea. Again, they did not have heart failure, they did not have coronary artery disease, they did not have renal disease, so primarily primarily referred for obstructive sleep apnea. And what they found is that these patients had severe obstructive sleep apnea. I'm sorry, I'm missing the mean AHI here, but no central apnea at the beginning. However, when they were placed on CPAP, as you can see, a number of subjects developed central sleep apnea with a mean of 14 per hour. So this would be really something that we define primarily as complex sleep apnea, i.e., they did not have central apnea on the initial PSG, they developed it on the polysomnogram. These are 20 patients that came to our lab for what the primary care physicians thought they were having obstructive sleep apnea. And so this is really different than a subsequent study that you do on subsequent patients. These are patients that were thought to have sleep apnea, and they were referred to us. You can see these individuals had a mean AHI of 64 per hour, and I want to emphasize that they had a lot of central apnea as well, but again, 64, 32 is central apnea index. One thing that central apnea in opioid shares with the central apnea in heart failure, and that's one thing they share, is that they both are non-REM phenomena. Non-REM phenomena. It is very interesting, as Richard correctly indicated, if you folks start to hyperventilate now while you're awake and drop your PCO2 to 20, 25, you will not have a central apnea. There is a mechanism in the brain that will prevent the development of central apnea while you're awake and hyperventilating. It's called short-term potentiation. However, if you go to sleep and I give you 2 breaths of big tidal volume with a mask, remove the mask, drop your PCO2 by 2 centimeters of water, a lot of you will have central apneas. So this wakefulness drive to breathe, is really a very important issue here. So now you remove the wakefulness drive to breathe, sleep comes in, and effect on respiratory muscles tremendous. Now you add opioids on top of the effect of sleep on breathing, you have a very bad mix, a very, very bad mix. So we have 2 things that are going on. Unfortunately, in 1997, when the publication came from the American Pain Association and so on and so forth, the statement was, if you have read those joint statement, the statement was that opioids do not cause much of respiratory depression. Well, that may be true while you are awake. Unfortunately, when you go to sleep with opioids, you have 2 effects here. The effect of wakefulness drive that was removed, plus the effect of opioids, and the 2 are very, very bad mix. So misconceptions really have been there to begin with, and then new statements about some of these drugs that could be used for dependency, they are equally bad as they were with the opioids. Right. Like what I said, in Ohio, I was really amazed that 5 people die a day because of the excessive use of opioids. Right. Heath Ledger, a thin man, was found supine, snoring in New York. And the maid walked into the room, and she saw him on his belly with snoring. And as you recall, he's a very thin person. And 3 hours later, he was dead. Autopsy showed nothing except a mixture of opioids and benzos. And this is true about almost all the people who die with opioids. Autopsy shows nothing except the drugs. The sine qua non of death is a long central apnea. So how do we treat opioid-induced sleep apnea? Well, if you could withdraw it, that would be great. I have one individual, a physician, who is on opioids for low back pain, and he works in a office with a bunch of psychiatrists, and he came to see me, and he had central apnea, and I went over things with him, and he's a physician. There was no way this man could come off his opioid. There was no way. No matter what I tried, he could just not come off his opioids. I have frankly failed in my practice to take patients off opioids. But now there are programs that are doing that, and I'm very glad, frankly, to hear that. Now, short of that, there are a few things that I would like to talk to you briefly about. Most of the studies are on positive airway pressure devices. And here we have 3 important devices, CPAP, which produces continuous positive air pressure, pressure, the bilevel that give you inspiratory support, which is fixed, and then the adaptive servo ventilation. Just show of hand, how many of you know about ASV devices? Okay, so not a lot, okay. And then there are a few other things. These devices are difficult to use. You know, in general, if you think really about CPAP, all these mask-based devices that the patients have to use night after night after night the rest of their lives. So there is a little bit of a problem there, a major problem there, I should say, with the compliance. These are some of the drugs that we have used with in congestive heart failure, with central sleep apnea. And most recently, I have been involved with the phrenic nerve stimulation also for central sleep apnea and congestive heart failure. It would be interesting to really look at some of these things and see how they may work in the context of opioids. This is a randomized double-blind study we did with acetazolamide in patients with congestive heart failure. So this is the baseline study, then this on placebo, and this on acetazolamide. If you look at the central sleep apnea, it decreased on baseline 44, on placebo 49. It almost went down by 50% with acetazolamide. And you wonder if acetazolamide would work in the patients with opioids, which really becomes very interesting when you think about how acetazolamide works on, what are the mechanisms by which acetazolamide works on breathing versus the opioid suppression of the prebosal complex in regard to central sleep apnea. But this is just one case report. Dr. Orr is one of the co-authors of this. This is a single case. So here is a patient with AHI of 34 per hour, obstructive sleep apnea 27, CAI is 7, arousal is 18 per hour, and the patient desaturates, placed on CPAP. When was placed on CPAP, you can see the AHI increased to 78, even though the obstructive disorder breathing were eliminated. The AHI increased because this patient developed a lot of central sleep apnea. So this patient had central apnea to begin with, 7 per hour, and increased tremendously with CPAP, and then was placed on acetazolamide, and you can see the central sleep apneas went away. What Richard was showing you was very interesting. So there is this rodent that has a terminal apnea with the PO2 going down, PCO2 going up, and they did not help resumption of breathing. Acetazolamide works really primarily on the receptors, the chemoreceptors I'm talking about. So it would be interesting to see really in the long run if indeed the chemoreceptors, the central peripheral chemoreceptors, can interact with the prebosal complex somehow to improve central sleep apnea, obstructive sleep apnea in opioids. Of course, use of a drug at night, because you give this acetazolamide at night before they go to bed, would be completely different than using the positive airway pressure devices. Now, Richard talked a little bit about the glutaminergic receptors in the proboscis complex and the AMPA, and I didn't see the abstract, Richard, that you were talking about. I guess this was presented yesterday? Oh, there was not. Oh, it's published already? Okay, because I missed that. So we'll see. This is one of the earliest studies that I saw in human, where in fact an opioid caused diminishing hypoxic hypercapnic response, which was reversed by ampakines. So, all right. And now we are going to positive airway pressure devices. So we had a number of patients that came to us with obstructive sleep apnea symptomatology, and on polysomnography they had this complex sleep apnea. We started to use CPAP as the first choice, and this is one of those patients. We started titrating up with CPAP, 5, 6, 7, 8, 10 centimeter of water, and really what happened was obstructive disorder breathing events were eliminated, but unfortunately central apneas persisted or got worse. Yeah, and no matter what the CPAP level was, you can see now a lot of central apneas on CPAP in this patient. This is the study that Guilleminault and Michel Cow were doing. Again, remember, these are patients primarily with obstructive sleep apnea. Here is their AHI, and they did not have much of the central apnea to begin with. They were placed on CPAP, and the central apneas increased. They did not work. A bi-level device with a backup rate helped them tremendously. So there is the choice of using the bi-level pressure devices. Now remember, if you are on a bi-level of say 15 over 7 centimeter of water, you have 8 centimeter of water pressure support, which is fixed across the night. Adaptive servo ventilation devices are completely different from the bi-level devices. And there are 3 such devices available globally. 2 of them are available in this country, and I mention the names because the algorithms are so much different from each other. One is the ASV device made by ResMed company, and the other by Respironics company. These devices have several things in common. They have gone through several generations. The most recent generations of these devices do the following. They have the expiratory positive airway pressure that can automatically, not manually, you can do manually if you wish, but automatically will titrate obstructive events. So automatic titration of like auto CPAP. Then they have the inspiratory support on top of the positive expiratory pressure. That the inspiratory support is variable. That's why it's called adaptive servo ventilation. It is variable and it is servo, i.e. it is a negative feedback system. It is anti-cyclic. If the patient is breathing a lot, the support will go down. Remember, in the bi-level, the support is always the same. But with the ASV devices, if the patient breathes a lot, the support will decrease. The patients breathe not much, the support will increase. Sorry for that. So this should be more patient-friendly, so to speak. The older generation of these devices, you had to manually use the positive airway pressure device to really eliminate obstructive disorder breathing events. And the algorithms are very, very much different from each other. If we do not know how these devices work, we will fail. We will fail. Like I always say, a fool with a tool is always a fool. We need to know how to really use these devices. If you are using these devices, you have to tell your technicians what to do because they don't know what to do with these devices. Anyway, this is one of those devices that we have done a lot of work with. This is the ResMed device, and you can see this is a patient on opioids and very successfully responds to ASV. And I'll show you more data. In our hand, both ASV devices have worked very well with opioids, and there are probably now 5 or 6 papers that I know about from 4 different centers using ASV devices for opioids. The idea was that when Australian scientists working with ResMed came up with the algorithm with the first ASV device, which was called AutoSet CS, the idea was, and this is a misconception, that the algorithm is really unique to congestive heart failure. But actually, that is a misconception, and there was never the idea that it has to be just for congestive heart failure. Remember, they have a backup rate, automatic backup rate, that normally is set at 15. So if breathing does not resume after a few seconds, the backup rate is activated, and the mandatory breath is given. So ASV devices, then you have the automatic EPAP titration, you have the variable inspiratory support, and then you have this automatic backup rate that I think make them effective in the context of opioids as well. But we certainly need more data. There was a recent paper published from Mayo Group. Morgan Tyler is one of the co-authors. I don't know if Peter Gay was on that paper or not. Peter, are you here? Were you on the paper also? I'm sorry? Okay. So they found that ASV devices was equally effective in congestive heart failure as it was in patients with opioids. But again, we need to learn much more about how ASV devices can be used in patients with opioids. Completely probably different algorithm is needed for congestive heart failure versus patients with opioids. So here is a patient of ours with one of these ASV devices. You can see I have the EPAP at 10, minimum support is 5, maximum is 10, and the patient is really doing well. So what happened is 20 patients was very interesting. So as I'm looking at these patients, trying to treat them, this is their CAI at the beginning. There are 20 patients here. And they first went on, this is not in order in here. for obvious reasons. But let me tell you how it happened in real world practice of medicine. So they came in, and this was their CAI. They went on CPAP, and when they went on CPAP, I realized that the CAI is not going away. And then I put them on, gave them about 4 or 5 weeks, bring them back and do a study again, and that didn't work. So finally we said, that's enough for CPAP in these patients. We started to use our ASV devices. You can see the central apnea index quite down with the ASV device. So at least in our hand, using ASV device with instructions to technicians as to how to operate it in the patients with opioids, different instructions for congestive heart failure. Patients with opioids can go with much, much higher pressure compared to patients with congestive heart failure. Patients with heart failure have a lot of hemodynamic instability. Their pressures need not to be as much. And we have shown that, and other people have shown that. So we need to be really careful about how to use and how to instruct our technicians with the use of these devices. As I said, the second phenotype of the central apnea in the context of opioid is that on initial diagnosis of the diagnostic PSG, it's primarily OSA. Then you put them on CPAP, and they have this so-called complex sleep apnea. And this is the Guilleminault work again, 42 patients coming in with excessive daytime sleepiness, and OSA was found in all. And they were placed on CPAP. These are some of the demographics, as you can see. They were all naive to CPAP, and they did not have coronary or heart disease. And on initial study, they had severe sleep apnea, but the CAI was 0.6 per hour. They put them on CPAP. AHI obstructive went to 0, but they developed a lot of central sleep apnea. And when they went on bilevel device with a backup rate, So you have the choice of either choosing a bilevel with a backup rate versus an ASV device. I think there are probably some differences. If the patient is probably severely hypercapnic, this is probably the way to go. If the PCO2 is not that elevated, ASV will be effective as well. I think ASV should not be used if the PCO2 is quite elevated. Now, remember, most of these patients on opioids do not have high PCO2s. So the statement from the American Pain Association is correct that diurnal hypoventilation is not really that bad. It's that when they go to sleep, things really go out of hand. Okay, so here is what we do in our center. Now, I have got the liberty here. I say that also before surgery, this should be done if it hasn't been done. So we do the sleep study, and if the sleep study is normal, you can go ahead with the operation. But really, post-op, these patients should be watched very carefully. As you may recall, FDA now has some publications. In Ohio now, the Ohio board has been writing to us about the post-op deaths that have occurred in patients undergoing tonsillectomy. They were on opioids and few more. So there are few publications now on post-operative death in patients that were given opioids. So we're going to be very careful about dealing with this. Now, if they have CSA, we generally will go to adaptive servoventilation. If they have OSA, we will go to CPAP, and then post-op, if that's what they're going to be on, they're going to be having an operation. We need to watch them carefully with pulse oximetry and what have you to make sure that they do not desaturate. Well, I have 2 more slides, and just wanted to remind you that Morpheus was the son of Hypnos, and in Greek mythology, Hypnos, of course, was the god of sleep. And that's the Romans called him Somnus. And I like Hypnos. Hypnos was a very gentle man, and the reason he was kind and gentle, because he had a very good sleep hygiene. And you know what a good sleep would do to you. It keeps you very calm. And it was very interesting to know that he could really put even other gods to sleep. Now, appropriately, his mother was Nyx, and she's the god of night. And Hypnos, of course, you know, he was in bed a lot, so he had a lot of children. And one of them was Morpheus. And if you recall, that movie with the Morpheus that would actually show up in people's mind and in their dream and what have you. So, of course, morphine and Morpheus are coming from there. And this is the very interesting part to me. The uncle of Morpheus was the god of death. You can see the connection. So, in conclusion, chronic non-cancer pain conditions are very common. Opioids, mainstay of therapy in many parts of the country. And a lot of these people are found dead in bed during the day, in the morning, in the afternoon. Death in bed syndrome. Death in bed syndrome. And the idea is that eventually a long obstructive central apnea is really the cause of death in these patients, because otherwise there is nothing else is found in these people. I think I'm going to stop here, and hopefully there are more questions that we can answer. Thank you so much for attention.
Thank you, Dr. Javaheri. So for sake of time, we'll take a couple of questions and then we'll move along, and then we'll have more on the Q&A. Any questions for Dr. Javaheri? There are many, so let's just take two. Tom?
Right. The story about the loop gain is very interesting. So one of the ideas about these central apneas is that it affects the provisional complex, and that's the mechanism. On the other side, Teichtal published a very good study several years ago. Unfortunately, he passed away. And that he showed that in individuals with methadone, the CO2 response was depressed, but the hypoxic ventricular response was heightened. And at least in congestive heart failure, that is one of the major mechanisms of inducing central apneas. The second thing that may increase loop gain in patients with opioids is, in fact, the fact that their PCO2s are upper normal limit or a little bit elevated. With that, the plant gain is increased. In other words, if your PCO2 is, say, 50, and you arouse from sleep, because the way the alveolar ventilation curve is there, at a PCO2 of 50, you increase your ventilation just a little bit, the PCO2 drops tremendously. That's called the plant gain. And when the PCO2 drops quite a bit below the apneic threshold, it can impose a central apnea. And thirdly, when we look at the pattern of breathing in these opioid patients, like what I said, sometimes out of the apnea, central apnea, for example, there are big breaths. So we're actually trying to, with people in Boston, to look at the loop gain and in these patients that are receiving opioids, which is a very interesting concept. Is it really the loop gain also elevated, or is it not elevated? So again, there are reasons to believe that loop gain may be elevated, although the CO2 response may be depressed. So two different things. Loop gain may be elevated, even though the CO2 response is depressed. The increase in loop gain would be through the hypoxic chemoreceptor, peripheral chemoreceptors, and the plant gain as I described to you. Again, the idea that you mentioned this yesterday also, and I did not agree with you about that. The idea that the ASV is just for that, in my judgment, is not the correct statement. Again, several centers have shown that these devices do work for not everybody will respond to these devices. There's no question about that, and we need more. I'm sure there is some sustained hypoxia because of perhaps sustained hypoventilation. These are the people who should go probably to bilevel with a backup rate. So we need to really figure out with more studies as to which patient best respond to ASV, which patient may respond to bilevel. Is the PCO2 level a critical factor here? Is the loop gain a factor here? So these are the things we need to do. We're just embryonic at this stage of the game with the opioids. Do we have time one more?
Maybe we should move on, and then we'll have Q&A, and then we'll take that question. So let me load up the next speaker. So I'm excited to announce Dr. Jackie Leong, who's professor of anesthesiology, one of our locals from UCSF, and she is doing very exciting work on an exciting area, which is delirium. And as you all know, delirium in hospitalized patients, intensive care unit patients, and postoperative patients